Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors Andy Hogan, Shannon Marcus, Amanda Matthews, Catherine Berger, and of course, Clay Smith. So here's the first article, which was titled The Association of Central Capillary Refill Time with Mortality in Adult Trauma Patients, a Secondary Analysis of the CRASH-2 Randomized Controlled Trial Data, out of the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine. Without a doubt, everyone will remember the CRASH-2 study, a huge study that really brought TXA to the forefront of everybody's trauma management. Now, this is a reanalysis of that data, so we're going to have quite a few patients. They reanalyzed about 19,000 patients, but they wanted to ask a different question. They wanted to ask, how useful is a central cap refill time? In this study, this was assessed on the sternum of these patients, and it was only assessed once, so we don't have any serial numbers or anything like that, or trends. We just have one cap refill time. That's it. They divided these cap refill times into less than 2 seconds, 3 to 4 seconds, or more than 5 seconds. Now, since the primary outcome of CRASH-2 was a 28-day mortality, that's exactly mostly what they were looking at in this study. And if you had an elevated cap refill time centrally, then you were at a higher risk of 28-day mortality. An odds ratio of 1.7 if your cap refill time was 3 to 4 seconds, and an odds ratio of 3.2 if it was over 5 seconds. Notably, this association held pretty true if the patients were not obviously in shock, so heart rate less than 100 and systolic blood pressure over 90. That's interesting. So it's kind of like more of an occult shock kind of thing. Now, I get this was a reanalysis, so we don't have a lot of choice over what the outcomes were, but 28-day mortality, I'd say that's appropriate for a treatment trial. It's just not going to be that useful for this kind of question. Most people don't have that hard of a time identifying sick trauma patients. And with only an odds ratio of maybe around 2 or 3, I'm not even sure what I'm supposed to do with this at the bedside as an easy bedside test to do. Like, sure, it's interesting, but I'm not going to consult my trauma team saying they look great, but they have a slow cap refill time. I'm not going to do that. That'd be kind of weird. It will contribute to my overall assessment, though, for how aggressively I'm treating this patient. Am I going to get blood into them even though they're not hypotensive yet? It really depends. So this could be a useful marker, but 28-day mortality, I'm not sure how that really speaks to how I'm going to treat that patient right then, right there. Also, just one measurement, it'd be nice to have it over time. Should I be doing a bunch of these? I gave 2 units of blood, redo it, seems better, I can stop now. There's still some stuff to get down into, to really dig into, to get more information on this. Now, I don't think anybody's going to do a trial nearly as large on cap refill times, so that's why it's nice that it's a reanalysis of this study, but of course there's a lot of limitations that come with reanalysis of data. Altogether, though, it's a fun study, but practically speaking, it's hard to actually apply to practice. In a spoonful, this reanalysis of the CRASH-2 trial provided a little bit more evidence that central cap refill times are associated with sicker patients even in trauma. Okay, let's skip straight to the third article, titled Validating the Falls Decision Rule, Optimizing Head CT Use in Older Adults with Ground Level Falls, out of the Canadian Journal of Emergency Medicine. Now, some people advocate for doing a CT head of every elderly person who falls, especially if they're on anticoagulants, but some people just advocate everybody gets a head CT. I think this is a little bit aggressive. There's good 80-year-olds and bad 80-year-olds, and you've got good histories and bad histories. If someone can really tell you they didn't hit their head and they're completely normal neurologically, you're not going to do anything about, even if they did have a small intracranial bleed. If you applied the big guidelines and it was very small, you could send them home anyways. So we don't always need to care per se, and we don't have to have 100% detection if it's not a clinically relevant bleed. At least that's my thoughts. Anyways, so there are people out there who are trying to make rules to decide for elderly patients whether or not they're going to need a head CT. Nexus didn't have that many elderly people. The Canadian CT head rules weren't applied for people over 65. So many people are looking for decision rules that apply to elderly populations. This study sought to externally validate the falls decision rule for older adults with ground level falls. Has to be ground level falls. This applies to the people who kind of fell out of bed in the middle of the night, in the bathroom, off the toilet. Those are all ground level falls. This decision tool says that you can avoid doing CT imaging of someone's head if they meet all of these criteria. The patient did not hit their head during the fall, as determined through patient history or a witness account. There's no novel abnormalities in their neurological exam. The patient retains the memory of the events surrounding the fall, and their clinical frailty score is below 5. Just for reference, a frailty score of 5 is people that are kind of independent, but they're going to rely on people for some of the higher order AIDLs. Patients were recruited at a level 1 trauma center, which had consecutive enrollments of everyone over the age of 65. Within 48 hours of a ground level fall, regardless of whether or not they hit their head. The decision to actually do a CT scan at the time of seeing the patient was up to the independent clinician. And so there's no rule applied at that point. Rather, they went through retrospectively, this is a trauma registry study, to decide whether or not it was appropriate to do that. Clinically important bleeding was defined as any medical treatment at all, even stopping medications or admission to the hospital, or if they required surgical intervention within 42 days of the original fall, or if they died as a result of the intracranial hemorrhage. Worth noting, they didn't just do the complete falls decision rule, they also did a quick falls decision rule, which only has 2 criteria. The patient reports not hitting their head, and they've no new neurological exam abnormality. These are relatively simple rules. Simple almost to the point of being insulting, though. Like, do we really need a rule to tell us that a perfectly fine patient who's sitting there who says that they didn't hit their head, that patient doesn't need a scan? What are scans really for? They're mostly for whether or not this patient needs an intervention or not. Ask your patient if they would want a hole drilled in their head right now. If they say no, then they probably don't need a scan. But these tools are pretty quick and easy. They were able to find 800 patients, a mean age of 79 years old, and 78% of them had a CT performed at this initial visit to the emergency department. 43 patients total were diagnosed with intracranial bleeding. You'll notice that there was no subgrouping or changes for whether or not the patient was on anticoagulation, and so you can apply this to all elderly patients. 4 patients initially had negative CTs, but at the follow-up in 6 weeks, they were diagnosed with an intracranial hemorrhage. And then there was 2 patients who were not scanned at the initial visit at all and were diagnosed with bleeding at the follow-up. When the falls decision rule was applied, 1 case of intracranial bleeding was misclassified as not requiring a CT head, and so you had a sensitivity of 98% and a negative predictive value of 99.6%, with a specificity of 32%. Overall, the rule would have reduced unnecessary CT scanning by approximately 32% overall in this cohort. When you look at the when you looked at the even briefer rule, you see that both tools were pretty much the same. When you look at the abbreviated version of the falls decision rule, you see that it performed pretty much the same. Actually, both tools performed pretty much as good as clinician judgment. Only 2 intracranial hemorrhages were missed by MDs on their own, whereas the falls decision rule missed 1 and the focused falls decision rule missed 3. So really almost equal numbers here. And keep in mind that some of those quote-unquote misses might not truly have been misses. You did a scan, the person did not have an intracranial hemorrhage, and then later on at a follow-up, it seemed that they picked them up in some patients. But they might have had a bleed later on. That doesn't mean that you gave bad care initially. I don't think that's a real miss, and so that's why I'm saying the MDs only missed 2. But if you read the discussion, you see that perhaps those 2 misses were patients that actually died before reaching the hospital again. And so were not scanned again. And they were still conservatively counted as intracranial hemorrhages that were missed. So the MDs in this study, just using their own clinical judgment, actually had perfect sensitivity because we don't really have any idea what happened to those patients or if we could have prevented it. And when you're looking at a cohort of 800 patients, mean age of 79 years, yeah, someone's probably going to die in the next 6 weeks. Though the rule still did well and would have scanned less patients. I think my takeaway from this, though, would be that you can comfortably scan fewer patients if they say they didn't hit their head and they're neurologically normal and probably not too frail. Do we need a decision tool here, though? I don't think so. Doctors are doing a really good job on their own. We just have to be a little bit more comfortable with not scanning some of these patients. So for that reason, perhaps this decision tool could be useful. However, it seems that doctors on their own seems to be the most sensitive for not missing any of these things. And so don't throw away your clinical assessment for a rule. In a Spoonful, we do a great job of picking up ground-level falls in elderly people that need CT imaging, but we could probably be a little bit more selective with who we scan. The falls decision tool, even when just using the focused version of the tool, may help us scan less. Okay, that's all the articles from this week. Let's do a quick wrap-up of everything we talked about. From the first article, not that I have a great idea of how to implement this in my practice. However, a central cap refill time that is prolonged in a trauma patient was associated with higher mortality. From the third article, while the harms of radiation are minimal in the elderly, the increase in length and stay is still significant if you decide to do a scan versus not do a scan. The falls decision rule seems pretty promising in this study to reduce the number of head CTs that we get, but mostly this serves as a reminder that not all elderly patients necessarily need a scan after a ground level fall. If you are hearing this right now, then you are not currently a part of the members feed, and so you missed 3 articles from this past week. What were those articles about? Well, we talked about BIG and a modification for validation in kids. From another article, we looked at whether or not you should be raising your MAP targets if the patient has chronic hypertension. And then lastly, what is the evidence for your post-ROSC targets? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.